Check one two. Yeah. Check check one two. Check one two. Yeah. Hello. 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 Check one two. Hello. Hello.
Hello, 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 hello. शुक्र ठीक है. Good morning, everyone. First of all, thank you very much for sparing your time on Sunday morning so early. So, uh, welcome everybody for this academic session. We have eminent faculty and speakers for this event. Uh, First session. Okay. So, I would invite Dr. Shelly Datta to start the proceeding of this first session.
Good morning, everyone. I would like, without much delay, we would like to start. So I would like to call the chairpersons for the first sessions, Dr. R.K. Gatani, Dr. Shiva Narang, Dr. Shubhashish Majumdar, Dr. Vivek Suman, and Dr. Ruby Bansal. Dr. Shiva Narang is a member secretary of GTB Hospital Ethics Committee. She is a professor in the medicine UCMS and GTB Hospital. Dr. Shubhashish Majumdar is a director and head gastroenterology, Max Super Specialty, Vaishali. Dr. Vivek Suman is a professor at the Lady Harding Medical College. I think Dr. R.K. Gatani is not available. Dr. Ruby Bansal is a specialist and specialization in lifestyle and HIV infectious disease expert and is a senior consultant at Max Hospital, Vaishali. I would like the chairpersons to kindly invite the speaker. Dr. Vinod Arora, I would like you to please come on the stage and do the presentation. Dr. Vinod Arora is Associate Professor at ILBS Hepatology, New Delhi. Please, sir.
Thank you. A very good morning to everyone, to the chairperson, and special thank you to Dr. Ajay, Dr. Nishesh, Dr. Amitesh for inviting me here. I'll be talking in brief about NASH and diabetes. And the brief outline of the talk will be how to define NAFLD, NASH, diabetes as a risk factor for NASH, the pathogenesis, the evaluation management of NAFLD in patient with type 2 diabetes, therapies, anti-glycemics, and briefly summarizing. So this is a normal liver. When there is accumulation of fat without no inflammation or no ballooning, it is known as non-alcoholic fatty liver, which with inflammation and ballooning progresses to a term called NASH, non-alcoholic steatohepatitis, progressing ultimately to cirrhosis. There's increased fibrosis, ultimately leading to transplant or death or the worldwide prevalence of non-alcoholic fatty liver being 25%, NASH 3 to 5%, and cirrhosis of these all 1 to 2% are at risk. This is the spectrum of NASH and concurrent diseases associated. The subclassification includes of non-alcoholic fatty liver disease that pure steatosis with mild lobular inflammation, then progressing to NASH with F0 to F1 fibrosis with and other is fibrotic NASH with more than more than or equal to F2 fibrosis and ultimately NASH cirrhosis. These are the concurrent diseases which can be associated with NASH. First may be alcoholic fatty liver disease, drug-induced fatty liver disease. Hepatitis C can be associated with some fat in the liver. The others can be heme chromatosis, autoimmune hepatitis, celiac, Wilson, deficiency of lipoprotein, hypopituitarism, hypothyroidism, parenteral nutrition, and inborn error of metabolism can be associated with fat in the liver. This basically shows the natural history of the NEFLD over long-term follow-up of this patient who have steatosis. 20 to 40% will progress to have F1 to F2 fibrosis. The patient can also progress directly to have high grade of fibrosis, or 8% of that. And this patient who have F1 to F2 fibrosis, of which 5 to 10 will progress to advanced fibrosis. And these patients who have F3 fibrosis, of this, almost half of the patient will progress to have cirrhosis. So, who is at risk for NASH and advanced liver fibrosis? The risk factor includes, which are commonly seen, are type 2 diabetes, obesity, dyslipidemia, metabolic syndrome, polycystic ovarian syndrome. The risk of advanced fibrosis is higher in patients who have relatives or first degree relative with NEFLD cirrhosis. So, what the guidelines recommend, who is at of risk for NASH and advanced fibrosis? As per ASLD, in diabetes mellitus type 2, suspect NEFLD and NASH and determine the risk of patient advanced fibrosis. The more the number of metabolic factor, increases the risk of progressive liver disease. Similarly, the NEFLD screening is recommended as per EASL and AD in patient with type 2 diabetes or metabolic syndrome or with elevated ALT or fatty liver. So as per the EASL, all the patient with steatosis should be screened for the feature of metabolic syndrome. All the patient with abnormal liver enzymes should be screened for NEFLD. And all the patient who have been diagnosed with NEFLD should be screened for metabolic syndrome with grade of evidence A and level of recommendation 1. So these two are the bidirectional disease, and they basically the prevalence of diabetes and NEFLD are more or less overlap. So coming on to the pathogenesis, this is briefly the pathogenesis which have been associated with weight gain, obesity, NEFLD. High caloric intake, excess of saturated fat, and high fructose intake, sedentary behavior predisposes to obesity and NEFLD. The genetic factor have been seen as a predisposing factor. Commonly associated genes which have been seen with the prevalence of NEFLD are PNPLA3, isoleucine variant at 148, and TM6SF2 carriers have been reported to have a higher fat content in the liver with the increased risk of NASH and advanced fibrosis. This briefly summarizes the pathogenesis and the progressive liver disease in the patient with NEFLD. There is a high visceral lactic fat, inflammation of the adipose tissue, and type 2 diabetes. There's an increase in long chain fatty acid, increase insulin state, increase in adipocytokines, and increase in long chain fatty acid diacyl glycerols, and increase hepatocyte triglyceride level, predisposing to the accumulation of the lipid and fat in the liver. And then there is these adipocytokine. They basically stimulate the stellate cells, which uh, increase the inflammation in the liver and increase the risk of fibrosis in the liver. The other factor which have been is the gut microbiota. There is a dysbiosis in the gut in the NASH patients. There is imbalance in the level of change in the bile acid level, which also predisposed to inflammation and increased fibrosis in the liver. So type 2 diabetes is a risk factor for NEFLD. This was a patient which was done in type 1 and type 2 diabetes. The prevalence of NEFLD in type 1 diabetes was 8%. However, it's reached up to 60 to 75% in patient with type 2 diabetes. This was who were naive to insulin, and then the patient, 61% in patient who were treated with insulin, type 2 diabetes mellitus. This basically shows how to diagnose an NEFLD in patient with or without diabetes. The prevalence of the NEFLD increased with the change in the technique with the plasma ALT level. There's around 20% of the patient who can be diagnosed with the NAFLD, which reaches up to 80% in diabetes mellitus with the use of a fibroscan or MR spectroscopy. So similarly, with the use of transient elastography or NAFLD fibroscan, the prevalence of advanced fibrosis in diabetes reaches up to 20 to 30%. So the metabolic factors associated with NAFLD, that is decreased clearance of insulin, increased resistance to insulin, predisposing to hyperinsulinemic state, uh, type 2 diabetes, increase in the cytokines and the inflammation promoting atherogenesis, increase in the triglyceride and the decrease in HDL level. They predispose to myocardial dysfunction and increased risk of cardiovascular disease. So NASH should be a part of screening test with everyone with type 2 diabetes. So this basically shows the routine screening for cardiovascular risk factor, diabetes, kidney disease, diabetic neuropathy, retinopathy, foot care, and NASH should be included as a part of screening, routine screening for patient with type 2 diabetes. So usually the presentation of NAFLD is asymptomatic and majority of the patient are diagnosed by chance, and most common symptoms usually which the patient presents to the OP clinics is usually fatigue. Other can be as incidental finding on a ultrasound. Many patients will present with grade 1, grade 2 fatty liver, and then abnormal LFTs. Common scenarios can be on annual reviews, medical insurance, or occupational health checkups. So the diagnostic protocol for the evaluation of NAFLD, patient should be screened for alcohol intake, the history of diabetes, hypertension, cardiovascular disease, the BMI, waist circumference, recent change in body weight, screen for viral markers, Hep B and C commonly, association or history of any steatosis associated drugs, uh, liver enzyme, AST, ALT, gamma GGG level, glucose, HbA1c, HOMA IR, complete blood count, lipid profile, sonography, and extended evaluation may include transferrin saturation or ferritin for the secondary iron overload, celiac or thyroid disease, polycystic ovarian diseases. So this is the algorithm for the patient with diabetes or impaired fasting pre-diabetes. If the patient is having normal ALT level defined as ALT of less than 30 in males and 19 in females, should be follow up with periodic evaluation. The patient has any of the high risk factors such as diabetes, more than 10 years, family history of cirrhosis or NASH, evidence of cirrhosis, HbA1c level of more than 8.5, high triglycerides, genetic testing is available, should be followed by MR elastography, transient elastography, or fibrosis biomarker panel. If it is having advanced fibrosis, maybe LSM on fibroscan, maybe more than 14, 15, should be referred to a hepatology care center and consider for liver biopsy. If it is indeterminate, and then a biopsy may be offered to the patient or follow-up can be done. If no advanced fibrosis, periodic evaluation and standard care should be offered. So liver enzymes are usually inadequate in assessing the NAFLD and NASH. It is neither indicative or predictive of NASH or fibrosis. Normal ALT does not preclude NASH or progressive disease. Elevated ALT cannot predict NASH or fibrosis. However, they warrant a workup for NAFLD. This basically shows that as the stage of the fibrosis progress, uh, the sensitivity and specificity of fibroscan in uh, picking up the liver disease is more they are more sensitive, and usually it correlates with the portal pressure of the pressure of the liver with LSM value of 20 kilopascal. The fibroscan should be avoided in patients who are having acute hepatitis, cholestasis, congestion of the liver, obesity, or any mass lesion predominantly present in the right lobe of the liver. So, what is the importance of diagnosing NASH and advanced fibrosis? Having any fibrosis, particularly fibrosis grade more than equal to F2, it is associated with increased risk of progression of liver disease and increased mortality. The patient will progress from F3 to F2 in 29, F3 to F4 in 29 months, of which in 19% of the patient with in another 30 months will have any clinical event which can be in form of jaundice, ascites, encephalopathy, or presenting as liver cancer. So integrated approach is needed to address obesity, diabetes, and NAFLD, offering lifestyle intervention to all, obesity pharmacotherapy, bariatric surgery, anti-hyperglycemic medication targeting cardiovascular risk and body weight reduction, and patient choosing the drug for the diabetes or weight management in patient with NASH. Whether NASH is reversible if the weight loss after this was a study which showed that the fibrosis resolved after bariatric surgery and weight reduction, it was persistent even after the follow-up. So coming on to the optimal therapy in patient with NAFLD and NASH. So basically, these are the three potential target, which can be glycemic control, improvement in the lipid profile, and the weight loss. Diet and weight loss are the only thing which have been proven till now to be the most effective therapy for the management of fatty liver. So these are the component of a lifestyle approach to patient with NAFLD: restriction in the calories, targeting weight loss of around 7 to 10%, long-term maintenance. Coffee is good for liver. Lowering down the or moderating the fat, moderating the carbohydrate, avoiding fructose-containing sugar drink, alcohol less than 30 grams in male, 20 grams in females, and physical activity of moderate intensity at least 3 to 5 times a week with 150 to 200 minutes per week, and promoting resistance training to improve the muscle mass. So these are the currently available therapies which have been used for NASH. First is the lifestyle, diet, and physical activity, GLP-1 receptor analog, SGLT2 inhibitors, bariatric surgery, endoscopic techniques for weight reduction like endoscopic balloon therapies, and targeting the hypertension, quitting alcohol, smoking cessation, liver-directed treatments such as vitamin E, pioglitazone, or saraglitazar. This basically shows how if we lose weight, there's a improvement in the liver. With 3% reduction in the weight loss, there's improvement in the fat almost in 35 to 100% of the patient. With 5%, there's improvement in the inflammation. And with 10% reduction in the weight loss, there's a regression of the fibrosis, which can be noted in approximately half of the patient. So there are no currently recommended pharmacotherapy which have been available for NASH or in patient with advanced fibrosis. And the most of the trials which have been done, I have been working on the reduction in the fat content in the liver. And initially they thought they were based on 1 point reduction in fibrosis, but usually or now they have changed to no worsening of fibrosis or no worsening of steatohepatitis. So many things have been used for NASH currently, such as semaglutide, which have been shown to promote weight reduction and hence improve the fat content in the liver. And there's a control trial which was done between semaglutide and canagliflozin. This showed basically the control of sugar and weight reduction was more with semaglutide as compared to canagliflozin. And this was a 48-week trial which was done in patient with liraglutide in patient with NASH. And semaglutide was associated with reduction in ELT and reduction in the fat content of the liver. However, no change in fibrosis was noted. Similarly, the SGLT2 inhibitors have been associated with reduction in the liver fat and the ELT values. However, there's no reduction in fibrosis which are noted with these drugs. So these are the summarize. This is the summary which have been the drugs which have been used to target the insulin resistance. However, all of these drugs have been associated with improvement in the liver fat without improvement in the fibrosis of the liver. So saroglitazar is a very commonly used drug nowadays. It's a dual potent PPAR alpha gamma agonist, and alpha agonism is more than the gamma agonism, and it leads to improvement in the triglyceride level and improves the insulin resistance. This basically this drug basically has been shown to decrease the fat in the liver by improving the insulin sensitivity, by reducing the fat content in the liver, or by acting on the de novo triglyceride synthesis and lipolysis, decreasing the inflammation of the liver by decreasing the activation of the stellate cells, decrease incidence of reactive oxygen species, decreasing the secretion of the VLDL from the liver, and it has been associated with decrease in the hepatic fibrosis by preventing the hepatic stellate cell activation and collagen deposition in the liver. So these are the this basically shows the PPARs which can be used in clinical practice. PPAR alpha has been associated with reduction in the triglyceride content. Gamma is associated with hypocholestemic and hypoglycemic action. PPAR alpha gamma is which we already discussed is hypocholestemic and glycemic action, and PPAR alpha delta is associated with the reduction of steatohepatitis. So the other, in brief, the techniques to reduce weight, especially in patients with cirrhosis, whom bariatric surgeries cannot be offered, can be endoscopic techniques, which can be endoscopic balloon deployment and tracheostomy or duodenal bypasses, which can be done, especially in patients with cirrhosis, with reduction of stiffness score in 28% in CAP and 10. So now moving to MEFILD, I'll briefly summarize. And diet should be recommended for all. As little as 3% can improve the fat content in the liver, and 10%